have nothing to do with inheritance. So the non-genetic factors could be viruses, you've got an infection of some sort, birth injuries, nutritional factors, trauma, a head trauma early in life, and that can affect sometimes the way the genes are working, or it just could be direct injury. So on page 245, they go over that. And basically what you need to take from that, to sum that up, it's schizophrenia is thought to be a genetic and environmentally non-genetic cause could be from brain trauma, viruses, birth injuries, but it's not one or the other. They believe it's both. So the non-genetic risk factors, prenatal stressors from birth, psychological stressors, family stress, environmental stressors, social adversity. A lot of times this happens in an age group where they're just getting ready to go to college, or they're in college, or anything when they're leaving high school and they're coming across adult stressors. And that can cause this to come out. Now what's interesting, people who are predisposed to becoming schizophrenic, marijuana use can spark at early onset. So now they also have here that methamphetamines and LSD, but especially marijuana, because you have cannabinoid receptors in your brain. And somehow things aren't working right and they're predisposed, and boom. So schizophrenia, of course I said it's one of the spectrum disorders, but there's psychotic orders other than schizophrenia that sort of look like that, and there's schizophreniform, brief psychotic episodes, schizoaffective, delusional, and a shared psychotic disorder called folie-à-deux. So the schizoaffective would be, it's a better prognosis than schizophrenia, but it's way worse than a mood disorder. So that would be sort of someone who's, let's say, bipolar, but they also have schizophrenic tendencies, like they may be psychotic at times with being bipolar. So they would be sort of the schizoaffective. So the shared psychotic disorder, that folie-à-deux, that's interesting because I don't think it's very common, but it can happen between two people who are isolated socially, and they sort of they become psychotic along with the other one. They just share it somehow. And you can have three people, and they call it like a folie-à-deux, and then four is a quattro. But that's just like an interesting note there. So now the course of the disorder, you want to focus on this on page 247. There's the prodromal, phase 1, phase 2, and phase 3. And you will want to know the order those go in, the numbers, and what symptoms go along with each phase. So the prodromal is the pre-psychotic phase. And phase 1 is the acute phase with positive and negative symptoms. And we're going to be going over what those are in the next slides. So the pre-psychotic phase, the prodromal, that is before the acute. They might start to withdraw a little bit more. Each person, I think, has their own little prodromal tendencies, sort of like you would have the prodromal and migraines. They're not all the same. But they might just start to withdraw more. Their cognitive function may start to deteriorate a little. And then they might start to have a little bit of magical thinking. And then they go into the acute phase. So with the acute phase, there is overt positive symptoms, which would be hallucinations, delusions, along with negative symptoms, which are more like depressive and flat affect. But again, we'll go over those. Right now, just concentrate on these here. And then there's stabilization, which you're going to try to decrease the severity, and maintenance, where you try to keep them in remission. So only about 20% of people diagnosed with schizophrenia have a favorable outcome. So the acute phase is what we know most. So on Friday, Ms. Edmonds was in the acute phase. So that's a good example. So know the order, and that the acute phase is more or less the one people associate that with. Any questions there? Okay, so there's 4 main groups of symptoms: positive, negative, cognitive, and mood. So in other words, in the negative, remember, anhedonia, lack of pleasure, that would be the negative. They just don't have a lot of motivation, they look apathetic, they have a flat affect, their thought process isn't good. And positive would be the hallucinations, delusions, and paranoia. So a way to remember those would be, I think of it this way: positive is like over the top, negative would be under, under what you would expect someone would be acting. So positive, negative, and cognitive, that's where, they can't focus, they can't use their language properly, and then their mood, depressed, anxious, suicidal. So you'll want to know those. And then here's an example of these. So this is on page 248, box 17.3, the positive and negative symptoms. So the positive, again, it would be hallucinations, delusions, disorganized speech, bizarre behavior. Negative is blunted affect, they can't process their thoughts well, lack of motivation, no pleasure, no joy, apathetic. And they can have both. They can swing back and forth. And then the mood, they could be depressed, anxious, suicidal. And then the cognitive, which is their decisions, their thinking, their judgment, their attention span. So with their alteration in thinking, this you want to be familiar with too. They might have concrete thinking. Does anyone know what concrete thinking would be? An example? They can't think abstractly. They can't. When you say something, it is literal. That would be concrete. So, in other words, let's say they're in a doctor's office. What brought you here today? A cab. So they can't think that you're trying to ask them what brought you into the office today. So concrete thinking would be not abstract. They can't think other than a literal thought. And then there's impaired reality, delusions. Of course, I think we know what they are. And then under the delusions, there's ideas of reference, persecution, grandeur, somatic, and jealousy. The two most common would be the persecution and grandeur. Does everyone know what the grandeur is?
Higher.
Grandiose. Nerl?
What I'm saying is like, something like over, like something is like higher, over.
Right. Something more than they really are. Is that what you're trying to say?
Yeah.
Yes. Like I'm Queen Elizabeth. something, it's grandeur, or, that they are way more powerful, they can fly, Superman. So be familiar with that. Okay. Also, here's something else to be familiar with. You'll want to get to know these. There's concrete again that we talked about. And then there's thought blocking, thought broadcasting. The fellow on the video, that was an example of thought broadcasting. That they can hear him, what he's thinking. Thought withdrawal, they think people can take their thoughts away. And then there's tangential thinking. He was also doing that. The fellow twisting his hair. He couldn't stay on the subject. And some people, it's different than going from one subject to the next and say, oh yeah, and then I was talking about whatever. With tangential thinking, you never ever get to the point you started. You never end up making the point you started out to make. And then you know what delusions are. Analogia is not being able to speak or have a content of speech well. So you understand concrete and tangential? Anything you have questions about with these? Okay, and then an example of alterations in speech would be associative looseness, thinking illogical and haphazardly. Neologisms. Do you know what that is? That's making up words. Made up words that mean something to them. Like, in other words, I want all you vetch kisses in the room to leave. What are vetch kisses? Or schmoigies, or something that's weird that nobody knows. They just make their own words up. And they may not even know what those words are tomorrow, but at the time, they're just making them up. And then there's cline association. That's rhyming meaningless words. I have a Big Mac in the stack, back, flack. And then there's word salad that's just a bunch of jumbled up words. They're not even rhyming. But that's what some of these mean here. And then neologisms are made up, totally made up. Okay, and then alterations in perception. We know that's part of hallucinations. And this is on page 249 to 250. Then they have personal boundary difficulties. So two of those would be depersonalization and derealization. So depersonalization is interesting because they think that they have lost their identity with their own body. So that, with depersonalization, they might look at their body and think their fingers are worms, or their feet are frogs. And so they really think that their fingers are turning into worms, or their feet are turning into frogs. I mean, it doesn't have to be those worms or frogs, but that's just an example. So be familiar with that too. That's a very interesting one. And then, of course, alterations in behavior would be bizarre behavior, eccentric dress, and different ways of grooming, motor agitation. They might look in a stupor or be very negative. And then hallucinations, that's the hallmark of schizophrenia, and I think you all understand what they are. But they're on page 249 also. And they can be auditory, they can hear voices, and they do, that's the most common, them telling them, you're bad, you're bad. Visual, they might see people, they think they're really coming into the house, or they might really smell odors that don't exist. Body sensations. Gustatory, that would be tasting things that aren't really there. And here's those negative symptoms: the apathy, the anhedonia, so they don't socialize well. So their affect may be flat, blunted, inappropriate, or bizarre. And then the neurocognitive symptoms, they have a cognitive deficit, disorganized thinking. So they would have a really hard time holding a job, having a support system, personal relationships, and of course, attention and memory. And then, so the physical assessment of schizophrenia, check for their self-care deficits, which could be very likely. Hygiene and grooming, because these could change drastically depending on what state they're in. Sometimes they can't perform, just the daily rituals. They may not know they need to eat or drink, or they may have someone telling them, don't eat or drink, don't eat or drink. So paranoia and fear. Polydipsia, they may be drinking too much, so then they're at risk for water intoxication. And that could lead to low sodium levels or possible seizures. And they might have sleeping problems. So now, with the depressive and other mood symptoms, recognizing this is especially important because of risk for, what can you imagine? Suicide. So especially depression and suicide. On page 251, they talk about that. So let's say they decided to give someone depression meds for their depression. If they were on depression medications, would you still be assessing them of their depression for suicide?
Yes.
Definitely. Not only it might not stop them from committing suicide, but the meds can lead to suicide. They have black box warnings. So be familiar with that. So how schizophrenia presents, we've talked about that. Paranoid, catatonic, disorganized, undifferentiated, and residual. Now, I want you to make a note on this, how schizophrenia presents, where they have these listed. These are not to be confused with the 4 main symptom groups. Remember those groups back where it showed the woman's head on your slide? That's not to be confused with positive, cognitive, negative, and mood symptoms. Okay? These are part of the things that come under those. But in other words, paranoid or catatonic. So catatonic would be, they might just be in a position staring for a long time like a wax figure. But that wouldn't come under one of the those four main symptom category groups. Okay, so don't confuse these with those. That might be a symptom of one of those, but that wouldn't be included in those. Does everybody get that? Okay. So this is these take a little bit longer, but I think these are kind of interesting. This is an example of someone in a psychotic episode. It's not, you'll see it can be different than what you saw with Charlotte Friday.
You are about to experience a brief simulation of a psychotic episode in a patient with schizophrenia. The symptoms you will experience represent a compilation of a range of sensory occurrences, as reported by actual patients.
Can everyone hear it?
Worthless.
He's waking up now.
Oh, the phone woke him up. Don't answer. They'll know who you are.
You're a waste of space.
Why are you so stupid?
Waste of our time.
Stupid. So stupid. Worthless. We hate you.
He's gonna pick up the phone.
They'll know if you lie. Something wrong. Weather.
Poison.
He's hanging up. Don't eat. Out to get you.
Poison.
They know about you. Poison.
The suspect was described as medium in stature but slightly youthful to me. Anyone with information about this incident is urged to contact.
They know. They know about you.
And another news, officials have closed the northbound.
Time for men. Don't do that.
Repair crews are on the scene. Now here's a story out of Chicago from last night. Two men posing as maintenance workers nearly made it out of the quick bite convenience store with the store's ATM.
Make a list. Make a long list. You are ungrateful.
You're a waste of space. A waste of our time. Get a coffee now.
Don't drink it. Stupid. So stupid.
That smells awful. Don't drink that coffee.
When the car told the man to call police, the pair took off. Left the machine.
Why are you so worthless?
So Scott, tell us how this weekend's weather.
Weather. Something wrong.
You know what, Chuck? They just don't stop in the weekend weather. You hear that word? Weather's going to get you.
Something wrong. Weather.
And what are you going to do about it, huh?
Something wrong. You have to stop it.
You're going to sit around, your stupid mouth open and do nothing?
You have to stop it. It's the weather. It's here for
Now
us.
he has to answer the door.
It's here for us. Do something. Stay in. Stay away from the
No,
door.
stop the weather. Protect us.
Pizza!
You didn't order anything. No, don't answer. You're stupid to open that door. He has to open the door now.
Here you go.
Don't do it.
He'll be in trouble. Poison.
This is for you.
This is for you. He's working with them. He's part of the plot. This is for you. Shut the door. Shut it. Don't eat it. Poison. You're stupid to open. I hate you. We hate
Here's some
you.
items for today's activities count.
And you need some activities, especially when you're lazy and you sleep too much. Stop staring.
I know what you're thinking.
He knows. Kevin, stop.
They're coming for you. You know this.
Part of the plot. Your mind.
Because you're so ungrateful.
Don't eat it. Poison.
No, don't open
He
it.
has to open the box.
This is entirely your fault.
Don't eat it. Don't eat it. Poison. Poison.
They're here. It is all your fault.
Oh.
No.
They know it's you. You're in
Don't
control.
open the
You
door.
hear that?
No, don't open it. Don't open it.
They're here. And it's all your fault.
You did it.
You should have used your mind to stop it.
Stop it. You have to take control.
Stop the door.
Hey, you all right in here? I called you. Why didn't you answer? I was like screaming, it's Lorraine! Into the phone at the top of my lungs. What were you watching? Do you even remember? Did the pizza oh! What happened here? Forget to take your medicine this morning. Well, you know it's not good to miss a dose. Well, it's not too late to take it now. Let's get back on track. And why are you standing here in the dark?
that can be pretty nerve-wracking. That constant, it just kind of builds, it's just voices. And at first I didn't know whether the pizza man was real or not, but apparently he was. Okay, so assessment. Of course, you're going to see, are they alcohol and drug dependent? And the command hallucinations. You want to find out, what are the voices telling you? What are those commands? Because, are they commanding that person to kill someone? Or, you want to assess that. Find out about comorbidities, their meds. Are they compliant? How does their family react to these symptoms? And do they even have a relationship with their family or a support system? And then, of course, the nursing diagnoses for the positive symptoms would be disturbed sensory perception, risk for self-directed violence, disturbed thought process, impaired verbal communication. And the negative, okay, of course, social isolation, impaired social interaction, loneliness, concerning self-esteem, violence, ineffective coping, self-care deficit, and constipation. And then interventions, of course, you want to definitely save their safety and the safety of others. And the safety would be suicide. How depressed are they, and are they seeing suicidal, or do they have any thoughts of it? Intervention for delusional thoughts, for hallucinations, coping with their inappropriate behavior, and client and family teaching. So, with phase 1, which is the acute phase, remember there was the prodromal phase 1, which was acute. With the acute phase, because what goes on in the acute phase with delusions, hallucinations, those voice commands, the goal, right up here at the top, overall goal is patient safety and medical stabilization. So you want to make sure their medication, they're adhering to that. And then phase 2 and 3, you're going to focus on helping them adhere to what you've done for them in phase 1. Help them to understand their diagnosis, be able to participate in activities that would be available for them, work on prevention of relapsing, and work on anxiety control. And it's important they maintain a regular sleep pattern, try to have them reduce alcohol, drug, and caffeine intake, have a support system, which a lot of times they don't, stay active, and a daily and a weekly routine schedule. But with that acute phase 1, know that it's acute and it's phase 1, and the overall patient goal is safety and medical stabilization. So that is actually bolded in your book. So in the planning phase 1, why might they need to be hospitalized? Right, or themselves or someone else. And of course, it would be strategies to ensure their safety and provide symptom stabilization. Then you want to know what you need to do for them at discharge. Living arrangements, financial situation, how vulnerable are they to stressors that could provoke another phase 1. But to sum all that up, it's patient safety and medical stabilization. And I believe that's on 254. Now the planning phase 2 and 3, you want to focus on their patient and family education skills and training. Relapse, that was in the previous slide. And then implementing phase 1 with the acute phase. Because phase 1 is the acute, right? So this might be done in a hospital, partial hospitalization, halfway houses, or day treatment programs. Does anyone know what a halfway house is? Right. It actually, some people sometimes have the idea it's for people coming out of prison, but it's, they stay at home, they live in a house with other patients, and they share the expenses, the responsibilities, and then they go out during the day, they attend sessions. But in that halfway house is a staff member who's there 24/7. So it enables them to try to be on their own. They're not in the hospital, but yet they have someone watching over them. So be familiar with that. Be familiar with those. And that's on page 257. They're all explained in table 17.5. So implementing phase 2 and 3, you want long-term for medication adherence, their nursing interventions, community support, teaching them about the disease, managing their meds, their cognitive skills and management, controlling anxiety. This is kind of a repetition of other slides. And you can read the rest of those. So communication would focus on lowering their anxiety. You don't want it to build. Decreasing their defensive patterns, which we'll talk about the defensive patterns. Try to raise their feelings of self-worth, because most of the time the voices are negative. Occasionally you'll hear someone say they're good, but it's very, very rare. They're telling them they're stupid, no good, it's their fault, everything's their fault. So of course, medication and compliance. So interventions would be watch for cues that they are hallucinating and just ask them directly. Of course, for command hallucinations, if there was any, if they said, you know, they were telling me to kill someone, you would want to report that. And then of course document it. Accept that the voices are real to the patient. And if you can say, I don't hear them, but you just don't want to confront them and say, you are wrong, you're not hearing those. You don't want to argue with them about that. And this slide even says it's okay if you say, you can tell the voices to leave, to go away. So, and for delusions, the patient's delusion is their reality. They really think it's real. So don't argue with them, identify their feelings. Observe for any triggers. And always the least restrictive means. So, you know, you might try therapy or PRN meds, but if that didn't work, seclusion or unfortunately restraints might be needed. Okay, so with interventions for paranoia, you don't want to be face-to-face. You don't want to go right and stand face-to-face and stare. You just kind of step to the side a bit, and don't react if they tell you to leave, or you know, that they don't like you, I hate you, you're doing all this to me. You don't want to react and look hurt that they've told you that. So you approach them in a non-judgmental, respectful manner, but be honest and consistent. And, you know, avoid laughing unless it's Miss Edmonds in the bed. whispering or talking about them. And then there's Nerl therapy, which, is a whole host of, did I move that? Let me see. There we go. So that's bringing in all types of different therapy together. But of course, safety is another key for them. And alternatives to hospitalization. There's that halfway house again, where they live in the community, in the house, sharing expenses and responsibilities, but who's there with them? Staff. So they would go out, to their programs during the day. And then psychotherapy. This can help with poor functioning patients, to help with relapses, try to get them social, but it also provides for crisis too, crisis intervention, help with cognitive therapy, and it can help reduce hospitalization. And then family therapy. So the families of schizophrenics, they can feel isolated too. So, teach them about the disease, alternatives to conflict, and help them to maintain the support system. And then there's the antipsychotic medications. So they can relieve the symptoms, but they're not going to cure, of course. If they stop the medications, the symptoms can return if they're not compliant. So antipsychotic medications are effective in acute exacerbations and to prevent relapse. So, on page 267, table 17.9, are the first generation antipsychotics. So, the first generation target the positive symptoms. That was before they had any for the negative. So, they help target the hallucinations, delusions, paranoia, and let's see. And the atypical targets negative and positive. They're the second generation. And we're going to go over those. As you knew, we probably would. So page 267, table 17.9, talks about the first generation for the positive symptoms. There's trifluoperazine, thiofixine, fluphenazine, haloperidol, which I think y'all remember from our SIM, the haloperidol, the Haldol, and pimozide, which your slide, I corrected it. It was spelled wrong, but I did not see that in the book. And then there's low potency, thorazine, and the medium potencies. So the first generation help with the EPSs, the extrapyramidal symptoms, akathisia, dystonia, acute dystonia, pseudo-Parkinsonism. So akathisia is, they feel restless. And this is all on page 263, 266, and the table 1710 on page 268. So with akathisia, they're restless. They just wiggly, and it's a movement disorder. Inner feeling of restlessness, inability to stay still. So they fidget, rock back and forth, pace. So be familiar with that, the extrapyramidal symptoms. And dystonia, acute dystonia, is when they have these muscle contractions, repetitive movements. And pseudo-Parkinsonism, that's a Parkinson's type symptoms. Now tardive dyskinesia, that one is repetitive body movements that are involuntary. They cannot stop it, which could be grimacing, making a face, sticking out their tongue, smacking their lips. They might also have jerky motions, but they have these facial contortions too. The bad thing about this is, this side effect, and I don't think it says it in your, might not say it in your book, but sometimes they do not go away when they stop the medication. And that's really sad when that happens. Now, what we need to focus on is neuroleptic malignant syndrome, because it is life-threatening. And the symptoms of that, and you'll want to be familiar with these, are high fever, confusion, rigid muscles. They might have diaphoresis, they might be drooling. And it is caused by the antipsychotic medications, because the antipsychotic medications reduce dopamine. And so due to the acute reduction, it can cause this neuroleptic malignant syndrome, which can be deadly, can be life-threatening. So they can, if it's caught early, so you can imagine you would want to be assessing and know your patient's symptoms for that, so that it can be reported early. And they do have medications for it. Parlodal, that's for mild cases, and dantrolene for severe cases. Dantrolene's a muscle relaxant. So they stimulate the dopamine receptors to try to get the dopamine back up. But what you'll want to take home with this is what those symptoms are: the fever, confusion, high fever, not just a fever, high fever, rigid muscles, so they're drooling. If their muscles are tight, they can't swallow well, diaphoresis, and the high fever. So,
Our book doesn't mention fever. Hyperexia. Okay.
so that's your take-home point there, to recognize what that would be, and that you would report that. Also, unfortunately, these first generation can cause agranulocytosis, so you'd want to do blood work. And they can also have anticholinergic effects. That's where the constipation comes in with that other slide. Orthostatic hypertension and lowered seizure threshold. Okay, so here's the EPSs again. You'll want to be familiar with this. 266. The side effects can appear early in therapy and be minimized with treatment. Sometimes they lower the dose, and they can prescribe the anti-Parkinson's medications, because the Parkinson's, their symptoms, so they give them this for the EPS symptoms. Usually, sometimes they develop a tolerance to the symptoms after a few months, but not always. So now here's your atypicals. So these don't have so much of the EPS, but look at what they do. Dyslipidemia, altered glucose, agranulocytosis, high seizure rate, the olanzapine that we're all familiar with from anorexia, weight gain, high lipids, risk of diabetes, invega, which is IM, weight gain, lipid abnormalities, diabetes, Seroquel, weight gain, lipid abnormalities, diabetes, the Risperdal, which is the risperidone, weight gain, lipid abnormalities, risk for diabetes, and Geodon, prolonged QT interval. So what do you think these people might end up with?
Metabolic syndrome.
Right, right. And that's going to be your take-home point there. So they take the first generation and they have EPS symptoms. They take these and they get metabolic syndrome. So that's on page 264, page 17.8. So you'll want to know that these can cause metabolic syndrome. And of course you'll want to be familiar with the medications. So with metabolic syndrome, of course, there's weight gain, diabetes, high cholesterol, hypertension, and of course, diminished self-esteem, which can lead to depression because they've gained all this weight. Now they have all these other problems too. Another problem is they're more expensive than the first line. So be familiar with that. So some of the adjuncts to the antipsychotic therapy would be antidepressants for severe depression, but then you run the risk of increased suicide. There's lithium that's the mood stabilizer that just helps stabilize the mood. However, that reacts with a lot of antipsychotics and they're more at risk for seizures. Benzodiazepine can sometimes improve the positive and negative, and clonazepine, which is the benzo, for anxiety. But just keep in mind, with schizophrenia and depression, there's an extreme risk for suicide. So you want to be sure that you assess for that. Oh, and for chapter 17, in chapter 4, review those pages that we talked about before. That's in your readings, page 43 to 45, 46 to 47, and 48 to 49, which go over some of the Parkinson's, but we went over these too. Yeah. Okay. I don't know if we'll get all through chapter 18, but I'm going to try to get through it. If not, we'll finish up with it on next Monday. Okay, now we've got neurocognitive disorders.